DMARD, including biologics. So let me first of all welcome this young brigade, which is unique. All of us have been introduced just now. Dr. Ram Chadha, the president-elect himself, is here to speak a few inaugural sentences to encourage us to start this meeting.
Good evening, everybody. On behalf of the Indian Orthopaedic Association, I am extremely impressed by the hard work put in by the BIOLOGICS, Orthobiologics, and the IORA group, which has probably been the most active subcommittee, both last year and in this year. And it is something worth really applauding yourself and patting your own back for. And it is something we are proud of. Why? Because we are surgeons at heart, and yet we realize that the best surgeon is the one who knows when not to operate. This is what we need to learn, profess, and practice. We have with us our seniors, Dr. S.S. Jha, Dr. Shantanu Lahakar. We have Dr. Manish Khanna, Dr. Dilip Majumdar, all in their own ways, very, very senior and very, very knowledgeable about this. We have Professor Ranjit Singh, Professor Chinmay Das, and a young brigade. All of them here to share their knowledge about rheumatology, for which they've actually taken additional training by visiting Lucknow. We have Professor Rajesh Gupta, who's the only one wearing a surgical mask right now, and hence hiding his face, because it's more of a medical discussion, but he's with us. So on behalf of the IOA, I welcome all of you. My dear friend, who's the editor from West Bengal, Dr. Sanjay Keshkar as well, and an entire young brigade who'll introduce themselves. And we'll go ahead with something that should be thought-provoking, captivating, intriguing, innovating, and inspiring. God bless you all. Let's move ahead. Thank you so much.
Thank you. Thank you very much. Dr. Thakkar, our Secretary General IOA, I think he has not joined still. So till the time that he is joining, I will request the President, Indian Orthopaedic Rheumatology Association, Dr. Shantanu or Professor Shantanu Lahakar, to say a few words. And all of us are aware that he's just back from California, where he had his governor's training for lions. Dr.
Thank you, sir. Namaskar. And first of all, I'd like to convey my gratitude to all of you. And I also welcome our President, Dr. Ram Chadha, President-elect IOA, our most respectable Dr. S.C. Jha, Dr. Manish Khanna, Dilip Majumdar, and all the faculty members. So this is the second webinar we are going to discuss on demise in special situation, which is very, very important, I think, for us also and for our newcomers. And from my side, I convey all my best wishes for this seminar for the subject, which is very, very important for all of us. So thank you, sir. Thank you very much.
Thank you, Dr. Lahakar. It has always been a great encouragement when our own leaders are there, including Dr. Ram, and who always is so stimulating. Well, friends, when we talk about DMARDs, they are conventional synthetic DMARDs, and all of us are aware the 5 of them: sulfasalazine, methotrexate, hydroxychloroquine, and leflunomide. Well, some of them will be repeatedly spoken by all the coming faculty members. The second one is targeted synthetic DMARDs. They are tofacitinib, baricitinib, which are available, and upadacitinib, which is likely to come in the Indian market. The biologics, all of us are aware, are there now and are being used by orthopedic surgeons also. So the biological DMARDs are mainly anti-TNF alpha, but now anti-IL-6, anti-IL-17, anti-IL-23, are there. The bio-originator DMARDs goes by the name BO-DMARD, and BS is for biosimilar. Dr. Ranjit has already told us in the previous webinar about biosimilar and biologics. They are carbon copy of the parent biologic drugs. Well, friends, while going through the discussion, we will come across various other drugs also, which are not included in this list, but when we will be talking about them, we can speak more about them. So why this topic, DMARDs in special situations? Only because there is a kind of scare when we start thinking of using DMARDs, and more so the biological DMARDs. Well, by discussing this, it is meant to boost confidence of we orthopedic surgeons by getting acquainted for their use in a special situation. So it is almost like catching them with both hands by their horns. So the topics that we selected are DMARDs, fertility issues, perioperative use, biologics, lessons learned in pregnancy, lactation, duration of therapy, complications, adverse events, and contraindications. Also, relevance of DMARDs in suspected tuberculosis and evolution of opportunistic infections. Well, friends, when we talk about management of rheumatology, it is not a very straight matter. So the systemic anti-rheumatic drugs, the DMARDs that we have been talking right now, they are being determined by factors present in the disease. So what are the factors present in the disease? Severity of disease, duration of illness, bad prognostic factor, and presence of deformities. Friends, I would like to overemphasize that history and history alone is so important in diagnosis of any disease, more so in rheumatology also. The patient factors also will be important, and they are comorbidities, infection, age, compliance, affordability, and safety. Friends, we must not forget that rheumatology involves younger people also. So the fertility plans of these younger patients are so very important. And so I invite Dr. Rameshwar Gupta, consultant orthopedic rheumatologist from Gwalior, Madhya Pradesh, who speaks on DMARDs and fertility issues. Dr. Rameshwar, I stop here. You share your slides.
Thank you, sir.
Share the screen. Right, your screen is visible.
Yeah, good introduction, and now we'll start.
Yes, open it. You will have to double click it. Right.
It is visible now, sir?
Yes, yes. Now slideshow mode.
Yeah, slide, enlarge it. Yeah.
On the top, there is slideshow, left-hand side. If you are facing any problem, you can go even in this mode. Yes, yes, slideshow. 1, 2, 3, 4, 5, 6, 7. Seventh one on the top in the red. Yes. Next, animation ke baad. Slideshow. After animation, upar.
Yeah,
On
upar,
the red
upar.
band. On the red band, there is slideshow above your
Actually,
arrow. above your
It is
arrow,
not.
Cursor के ऊपर, cursor के ऊपर.
cursor
Sir,
के,
actually, one screen is there, one overlapping is there. This is. Oh,
okay,
yeah,
fine.
now,
Yeah,
okay. Slides.
Yeah, right. And now left hand side में red band के नीचे, first from beginning. हाँ, yeah, that's very good. Yeah, go ahead.
Very nice. Very good.
So, good evening, everybody. Namaste. Today we will discuss about DMARDS and fertility issues. So, it's a very important topic, but unfortunately, very small, very few studies were conducted on this particular topic. So, a young male or female willing to go for pregnancy, what we can offer for their rheumatology management. Actually, very little evidences are available relating to the safety of disease-modifying anti-rheumatic drugs in young patients with inflammatory rheumatic disease wishing to conceive. Studies shows that DMRD affect this fertility, but it never affect libido. NSAIDs and corticosteroids are the essential part of prescription in the initial phase of treatment for RA. So let's start with NSAIDs. NSAIDs inhibit the production of prostaglandins, which play a role in ovulation and blastocyst implantation. It delayed ovulation by approximately 5 days. So it's better to reduce the doses or stop before planning to conceive. Then the glucocorticoids. Prednisolone in a dose of more than 7.5 milligram daily and other glucocorticoids affect fertility is possibly due to transient suppression of the hypothalamic pituitary ovarian axis or a direct effect on ovarian function and or endometrium. So it's better to keep these in lowest doses. Then start with DMARDS. The gold standard is methotrexate. Recent study shows that prior or short-term methotrexate treatment does not affect the time to pregnancy and ovarian reserve and does not compromise fertility. Fortunately, because this is the mainstay of drug, as we know very well, is the mainstay of main drug for the treatment of RA. But it should be stopped 3 months before the planning, as safety data are not conclusive. Then the hydroxychloroquine data is surprisingly limited for such a commonly prescribed drug, but available papers didn't raise any concern about the parenteral exposure. The BSR guidelines state that men should not be discouraged from taking hydroxychloroquine while trying to conceive. So it's a safe drug. We can prescribe hydroxychloroquine for the young rheumatology patients. Then comes sulfasalazine. Yes, it's a documented. All studies noted poor sperm parameters in patients treated with sulfasalazine therapy. And in most cases, but fortunately, in most cases, these resolved within 3 months of stopping treatment. So can be prescribed, but stop before 3 months. Then comes leflunomide. It's a pyrimidine synthesis inhibitor. Study shows its use affect fertility in both male and female, and also reported teratogenicity. So must stop therapy 24 months before the planning or undergo an urgent washout with cholestyramine for reassuring pregnancy outcomes. Then come azathioprine. It's interfere with purine metabolism and inhibit both DNA and RNA synthesis. The majority of studies were reassuring about the effect of azathioprine on semen parameters, but better to avoid as conclusive data safety are not available. Then cyclophosphamide, it's a documented. Almost universal reporting of reduced sperm counts, including azoospermia and teratospermia. Some improvement reported after cessation of treatment, but can cause permanent infertility in male and female both, as it also affects ovarian reserve. So must not be prescribed to young patients. Then come to anti-TNF. Adalimumab, setalimumab, infliximab, etanercept. Study fortunately shows improved control of inflammatory diseases with anti-TNF therapy was generally associated with improved semen parameters. This is good thing. We can go with anti-TNF. Other facts shows interleukin-1 blockers like anakinra cause decreased implantation in mouth models. Interleukin-6 blockers like tocilizumab causes recurrent miscarriage. Interleukin-11 blockers decreases preparation for implantation, so should be avoided. Since only few studies were available in this important topic, so what I could collect. Thank you so much.
Thank you.
Thank you. Stop sharing. Well, I must say that you have done wonders to the topic, and I can say that it can be a pathfinder for all the subsequent speakers.
Thank you, sir.
Well, when you were talking about azathioprine, cyclosporin, I was reminded that these two drugs were not included in the list of DMARDs.
DMARDs.
So a great question arises that should they be called DMARDs or they should be grouped under something else? So they are in fact immunomodulatory. They were basically called immunosuppressive drugs, and most of them are in use, were in use in treatment of rheumatology earlier, not so much in particularly rheumatoid arthritis or spondyloarthropathy.
Yes.
Though they still have a role that when we want remission to take place, we can use azathioprine to enhance remission. So we must remember that there are separate class of drugs under the heading immunosuppressant, which can better be called immunomodulators. Number one. Number two, you have rightly said that paternal exposure to the drugs concerned, and you have discussed them. There are luckily reversible changes in spermatozoa count and motility, etc. with sulfasalazine, whereas with azathioprine, it may not be so.
Yes.
Is that all right?
Yes, sir.
All right. Lefnomide, we will be discussing in so many topics. So here what I say is, rheumatology patient wishing a child, there was a gap in knowledge regarding the effect of DMARD on fertility in women and especially men. Do disease-modifying antirheumatic drugs affect male fertility and periconceptional paternal exposure? You have rightly answered it. So the paternal exposure, spermatogenesis, adverse impact of cyclophosphamide, sulfasalazine, but there is no harm to fertility or pregnancy outcomes. Anti-TNF therapies, you have very much clarified. Others, abatacept, rituximab, azathioprine, and so on and so forth. They also have to be looked into, but chances are that they produce no harm to fertility or pregnancy.
Yes.
Male and female pregnancy are issues we will be discussing many a time subsequently, so we leave it at that. Now, Professor Ranjit Kumar, who is professor and head of orthopedics in Nalanda Medical College, Patna, will be speaking on occasions where we as orthopedic surgeons operate. So mainly he will be talking about orthopedic surgery that is being contemplated. So what peri-operative use of DMARDs, what is the kind of approach? Professor Ranjit. Professor Ranjit, are you there? Professor Ranjit?
Just to share the,
No, I will stop share. And Professor Ranjit, are you there? I think he has lost contact, something urgent. Okay. In that event, we
can pass it to the next speaker.
next speaker. Can somebody say who is the next one?
Sir has came.
Sir, Ranjit sir is there. He has joined.
Ranjit, are you there?
So again he left.
He again left. Something happened to him. I think after Ranjit, it was SS Jha himself. Okay. So, Ranjit, are you still there or not?
No, he is not
Sir,
there.
he has
Sir.
left. He's not there.
Okay, some emergency must have been there. So let me see if I
No,
can.
he's joined again.
Okay, again. Ranjit.
Yes, sir, he has joined.
Okay.
Already he's sharing. He's sharing.
Okay. So I will again stop share.
Yeah.
Ranjit,
Yeah, you please.
we cannot hear you, Ranjit. You are muted.
Ranjit is from Patna, you know.
Yes. There must be some emergency. He comes and goes. What happens? His net.
You may continue yours, so it will be
Okay. Okay, so this will be coming later. This is my presentation, Biologics Lessons Learned. I'm not talking about all the DMARDs. I am only restricting myself regarding biologics. We had detailed presentation during first webinar, and I just wanted to sum up. So, biologics in orthopedic rheumatology. Ranjit, are you ready?
There is some problem with my board.
Okay,
Right,
so
sir. That's why I was trying to solve it.
in the meantime, I am making my presentation. You be ready after this. So friends, when we are talking of biologics, they are cytokine targeted therapies. They are TNF-alpha inhibitors, TNF-alpha inhibitor biosimilars, IL-1 inhibitors, 6 inhibitors, 12, 23, which goes by the name of ustekinumab, IL-17A is secukinumab, ixazumab, IL-17 is brodalumab, and IL-23, anti-IL-23 is guselkumab. Well, all of us have used by now the B-cell targeted therapy, the famous rituximab, which is anti-CD20, and B-cell growth factor inhibitor, belimumab. In fact, we will be at some place talking about merits or demerits of belimumab as well. The T-cell targeted therapies, anti-CD80 or 86 is abatacept. Today, we have kept the B-cell and T-cell for the next webinar, so I will be restricting myself to the other ones. Well, friends, biologics function at a glance. All of us can see that the APC, antigen presenting cells, and they work through the T cells, where macrophage and B cells are further activated, and abatacept, tocilizumab, anakinra, etanercept, they all come in this mechanism of action. This is a slide from Dr. Chinmay, and I like this slide, so I put it here. Now, what is the ideal treatment target? What we want to achieve? Remission, that is sustained, drug-free or persistent, or low disease activity. So, what is the kind of flow chart of therapy with DMARDs? As rightly pointed out by Dr. Rameshwar, that it starts from NSAID and subsequently anti-rheumatic drugs, or maybe along with NSAID, we start using anti-rheumatic drugs. So they are DMARDs and adjuvant drug. Adjuvant drug, glucocorticoids have to be added from time and again as this situation demands. In the disease-modifying anti-rheumatic drugs, we have non-biologics, which we all have talked about. They are conventional synthetic DMARDs. Then the next one could be targeted synthetic DMARD, or parallelly, they are biologic agents, which are TNF inhibitors or non-TNF inhibitors. Now, where comes the role of use of biologics? Only when the disease is either moderate or it has high disease activity. So, if there was a DMARD monotherapy for a early stage of the disease, then prefer methotrexate monotherapy over hydroxychloroquine or sulfasalazine. But biological DMARDs and targeted synthetic DMARDs will come into play when they have not succeeded. Again, if methotrexate plus non-TNF inhibitor biological DMARDs do not work, then alternatively, we can add targeted synthetic DMARD. So, by this slide, I want to say that the role of inducting biologic is only when monotherapy or dual therapy fails. So, a non-responder patient who was initially moderate or was having a severe disease, combination conventional synthetic DMARD therapy, dual therapy or triple therapy. The second one is targeted synthetic with or without methotrexate. Third one is leflunomide, but alternatively we can use in non-responders TNF inhibitor with or without methotrexate. All of us are aware the benefits of mixing methotrexate with TNF inhibitor, or for that matter with any other DMARD, that the ADA, anti-drug antigen, is not formed. Even alternatively, non-TNF inhibitor with or methotrexate can be used if it is not successful. Now we can get methotrexate naive, but conventional synthetic DMARDs treated patient. So all others have been given, but methotrexate was not given. So moderate to high disease activity, always prefer methotrexate over combination with biologic DMARDs or targeted synthetic DMARDs. Now, rules for use of glucocorticoids, also I would like to mention that on initial conventional synthetic DMARD therapy, prefer not to use glucocorticoid, but can be used on initiating or changing conventional synthetic DMARDs. Initiate short-term, less than 3-month glucocorticoid for rheumatoid with disease flares. Considered using them for short-term. Number 3, long-term glucocorticoid, which is more than 3 months, moderate or high rheumatoid arthritis disease activity, or DMARD failure or biologic failure. So only these 3 situations glucocorticoid should be used for more than 3 months. To provide best benefit risk ratio for the patient, use of glucocorticoid, which should be there, we say lowest possible dose for shortest possible duration. Risk of long-term glucocorticoid therapy is always to be evaluated. Use acceptable glucocorticoid dose, and risk of harm is generally low at long-term dose of 5 milligram or less per day. Taper glucocorticoid as rapidly as clinically feasible. Well, we say go low, go slow to early use of DMARD. From pyramid approach of DMARD monotherapy, we can step up by using a combination therapy or treatment targeted tight strategy. Then we can climb down to early step down combination therapy, which will be inverse pyramid approach. Friends, what is the future? Well, understanding of various pathways behind initiation of the disease, and number 2, perturbation of immune regulation. That new targeted interventions at individual patient level will influence mechanisms driving occurrence of sustained drug-free remission. And normally we do not say cure is possible, but hopefully future is looking towards offer of a cure. Well, talking about spondyloarthropathy, in active ankylosing spondylitis, despite use of NSAID, the second line of treatment, the first choice becomes use of TNF-alpha inhibitors. The second choice could be secukinumab or ixazumab, and the third choice could be tofacitinib. But if ankylosing spondylitis is associated with either uveitis or inflammatory bowel disease, prefer monoclonal antibodies like infliximab, adalimumab, certolizumab, golimumab, or other biologics. Well, friends, are there use of traditional DMARDs? I love to put this slide because I would advocate recommending using traditional DMARDs de novo in higher doses or following biologic therapy when cost is a constraint, which usually is for most of our patients. Sulfasalazine, even otherwise, has potent anti-inflammatory effect similar to NSAIDs, and also it has antibacterial and immunomodulator properties. In psoriatic arthritis, higher doses of methotrexate have been seen to be more effective, and results are comparable to rheumatoid arthritis, and remission is achievable in 20% of psoriatic arthritis. So friends, we have to proceed step by step as per the guidelines that I have enumerated and achieve target for therapeutic strategy, which could be either remission or low disease activity. Thank you very much. Okay, so now we switch back to Dr. Ranjit, who is now ready. Ranjit, are you ready now?
Well, where is mine?
Ranjit, I stop share. Right, Ranjit.
Okay, I'm trying, sir. There is some problem, I think.
Okay, so we will go ahead in that event.
देखिए दवा हो गया. I would.
Okay.
Yes,
So,
sir. I got it.
Okay, fine.
So, good evening, everybody.
Yes.
The subject I have been given allotted is when and how to stop DMRs, both conventional and newer the biologics. So What is the objective? Every one of us is very anxious and sometimes jittery while operating upon the people who are taking biologics or DMARDs, what to do. So there should be a consensus and there should be guidelines. So to enhance patient
Professor
safety.
Rajit, sorry to interrupt you. We cannot see your slides. Kindly share your slides.
Okay, you are not
Share-
able to see it?
No. Share the screen first. You have not shared the screen.
How to share?
नीचे में there is a green button, share screen. You just click over it.
He has
Green button down, yeah. Green button.
Share screen.
Where is share button here?
Green, share screen.
Where is share?
Share screen. नीचे में
सबसे बॉटम में उसको टिक करिए तब भी आ जाएगा. Are you getting share screen?
एक ग्रीन कलर का बटन होगा.
सबसे पहले है म्यूट, फिर स्टॉप वीडियो, फिर सिक्योरिटी, इस तरह से फिर चैट है, चैट के बगल में है शेयर स्क्रीन.
सर नहीं तो आप कर दीजिए सर. झा सर.
नहीं, मेरे पास वो प्रेजेंटेशन लोडेड नहीं है डॉक्टर साहब का.
ओके.
नहीं, शेयर इज यस.
Sir, now you can save it and you can open it, sir.
Yes.
Ranjit, sir, you can download it. Download the PPT, save it. Once you save, it will be saved in your. Now you open that. Open that. It is showing yellow color. No, in open. Download completed. Open.
Is it visible?
No.
No, sir. You have not opened that
Open it.
PPT.
PPT, you have to open the PPT.
Sir, you have downloaded, na? Abhi to you have downloaded, right?
इसके पहले भी अच्छा रहा.
ये वाला है ये.
Sir, again, once again, you download, please.
Download your biologics PPT. Download that.
So once again, please download that biologics PPT.
सर इन द मीन टाइम हम लोग
Yes, we can proceed, right.
मदन को या
So for that, sir has to
stop
stop
share.
sharing, na?
आप स्टॉप शेयर कर लें रंजित.
स्टॉप शेयर कहाँ करेगा?
हाँ, he will stop share. क्रॉस कर लीजिए कुछ. नहीं, स्टॉप शेयर है ना, कहीं पे ऊपर में होगा. हाँ, आप ही को दिख रहा होगा. स्टॉप शेयर ऑन द टॉप. Dr. Ranjit, please stop share. टॉप में स्टॉप शेयर है.
यहाँ मोर पे चाहिए.
नहीं सर.
One of right now you have to stop sharing. Okay.
Yeah, Madan.
It was Madan's paper now.
Yes, sir.
Madan, are you ready?
Yeah, I'm ready, sir. I'm ready.
No, it is not Madan's paper. Madan is later.
No, sir. After Ja, sir, your
Yeah,
topic, my topic.
Madan. Yes, please go ahead.
Madan is there.
Right.
Yes, sir. Shall I start sharing the screen?
Sure, sure.
Madan is smart, he can share quickly.
I'm sharing my screen.
Right.
So today's topic for discussion is DMARDs in pregnancy and lactation.
Right.
So this pregnancy and lactation is the important period which has both immunocompetent state and immunocompromised state. So this is the physiology of pregnancy. During pregnancy, when the fetus is inside the uterus, the FC fragment and the FAB fragment both can cross from maternal circulation to fetal circulation via syncytial trophoblast. So while doing that, there will be ability to produce cyclinization of peptides by the enzymatic action and activation of APCs through the effect of toll-like receptors. Hence, the antigenic mimicry happens. Along with that, the control of your host immune system will also be altered, which alters the intestinal mucosa as well as increase the T helper 17 cells. So that proceeds with a disturbance in gut microbiome during pregnancy and lactation, which all have an effect towards the autoimmune mimicry, leads to swelling of joints and pannus formation, leads to cicatrization. This is how rheumatoid arthritis present during pregnancy and lactation. So during various stages of pregnancy, early pregnancy, during pregnancy and delivery phase, there will be altering pro-inflammatory environment and anti-inflammatory environment. So while during pregnancy, there will be always an anti-inflammatory environment by nature. But when the pregnancy is going to end during delivery, that things will change to a pro-inflammatory environment. That is what being shown in this image. The next one, which shows there will be altering in pro and anti-inflammatory, but during the process of pregnancy, there will be always an anti-inflammatory environment, which will have raised T regulatory cells, gamma T cells, and M2 macrophage, which is very important, which will give you anti-inflammatory environment. Along with that, TNF receptors, interleukin 1 RA, that is RA is nothing but receptor antagonist, and interleukin 10. All these things are anti-inflammatory molecules, which will be very much raised in during pregnancy. That is what called feto-maternal immune crosstalk. During that crosstalk, anti-inflammatory molecules are more, hence the pregnancy can be continued. So this is the general chart which shows what are the baseline drugs we have to follow during pregnancy and modification during severe and very severe disease. In that, let us take, for example, if it is a rheumatoid arthritis or any other inflammatory arthritis, it is recommended that HCQ, sulfasalazine, and TNF alpha inhibitors are very well tolerated and we can continue during pregnancy. If there is any increase in rheumatic condition, that is arthritis, inflammatory arthritis, at that time we can add low dose glucocorticoids, which should not exceed more than 10 milligram per kilogram. Then at very severe modification, we can increase the glucocorticoids, which will help in the maturation of the pregnancy as well, along with tacrolimus and cyclosporin, plus or minus we can add. So when a RA patient in the reproductive age group first ascertain pregnancy, if there is no pregnancy is confirmed, we can go for pharmacotherapy along with contraceptive counseling we have to give. That is the genetic counseling. What is the risk being involved in taking the DMARDs? If there is a pregnancy, yes, what all has to be discontinued? Methotrexate, leflunomide, abatacept, all the biologicals have to be discontinued. Again, assess the activity of disease. If the disease is of low inflammatory condition, start with NSAIDs, paracetamol, and low dose glucocorticoids. Among DMARDs, HCQ, sulfasalazine can be considered along with anti-TNF alpha inhibitors. If the disease is very high, still postpone the pregnancy. This is prior to the pregnancy I'm talking. So postpone the pregnancy until the disease is low or in the remission phase. So therapeutic good administration in this pregnancy and lactation, we have 4 categories: A, B, and C, D, and X. X is completely it should be avoided because permanent damage to the fetus will be occurred. So coming from A, in A, the drugs, the category A means the drugs which can be consumed by large number of pregnant women and reproductive age women, which doesn't have any effect on the fetus. B1, B2, B3, they have only limited number of pregnant women has been taken these drugs. B1 shows no evidence of fetal damage in animal studies. B2 shows the data is lagging in animal studies. B3 shows there is a definitive fetal damage. And in class C, there will be a definitive harmful effects on the human fetus and neonates without any malformation. But class D will have definitive malformation, which is irreversible. So according to these classes, the drugs are being classified. So here is the classification according to that corticosteroids, sulfasalazine, TNF-alpha inhibitors, anakinra, and NSAIDs is class B, and COX-2 inhibitors, HCQs, rituximab, biologicals all comes under class C. Azithromycin will come under class D, and methotrexate, leflunomide, which has a definitive fetal anomaly, which comes under class X, which should be definitely avoided. This is during pregnancy. Now, during lactation, what are all contraindicated? The same type group of drugs are contraindicated. That is methotrexate, leflunomide, azithromycin are contraindicated, completely contraindicated. And there is the data for very safe drugs during lactation of NSAIDs, corticosteroids, hydroxychloroquine, sulfasalazine. But the sulfasalazine has to be continued with the caution of fetus for being a premature baby or a hyperbilirubinemia can be noted in the fetus. Inadequate data is there in the biologicals. So before pregnancy, what all has to be started? Folic acid supplementation 3 months prior to the conception and has to be continued toward the pregnancy to avoid neural tube defects. NSAIDs is considered safe in the pregnancy, but there is a minimal risk of miscarriages. Glucocorticoids, though it is safe, but it has a risk of congenital anomalies in the before pregnancy if we give. So methotrexate has to be stopped 3 months prior to the conception. If a woman is found to have consumed methotrexate, medical termination, elective termination of pregnancy has to be done. Medical elective termination has to be done. Then if it is a HCQ, it is absolutely safe, we can continue the pregnancy. Leflunomide, it causes some miscarriages, abortions, and hyperbilirubinemia. So this has to be discontinued at least 2 years prior to the conception. Here comes family counseling has to be given for the couple. And sulfasalazine and azithromycin, it can be continued throughout pregnancy. During pregnancy, what all can be done? NSAIDs has to be used very cautiously because in third trimester, this NSAID will lead to PDA closure, that is premature closure of patent ductus arteriosus. Then if we use prednisolone to decrease the inflammatory phase of the disease, less than 10 milligram per day has to be consumed if NSAIDs are contraindicated. Other than other DMARDs like HCQ, SARS, that is sulfasalazine and azithromycin can be continued throughout pregnancy. Leflunomide and methotrexate should be avoided at any time of pregnancy. If found methotrexate and leflunomide has been consumed by the women of reproductive age group, it can be counseled for postponing the pregnancy. If they are continuing during the pregnancy, medical elective termination of pregnancy has to be recommended. What is the postpartum management? This is nothing but this is during lactation period. Lactation period through breast milk, it can pass on to the fetus. So what are precautions we have to take? NSAIDs can be used, but aspirin has to be avoided for the during lactation period because it may cause further bleeding in the child if it pass on to the child. Next, glucocorticoids less than 10 milligram already we have seen. DMARDs, HCQ, sulfasalazine and azithromycin can be continued. And TNF-alpha inhibitors is absolutely safe and we can continue. Again, methotrexate, leflunomide is avoided in breastfeeding women along with Janus kinase inhibitors and synthetic DMARDs have to be avoided in lactating women. So EULAR has come out with the guidelines in 2016, 4 overarching principles and 11 points to be considered for the use of antirheumatic drugs during pregnancy and lactation. So what are all compatible during pregnancy? Anti-malaria, that is HCQ, sulfasalazine, azithromycin, cyclosporin, tacrolimus, colchicine, immunoglobulins, and glucocorticoids are compatible with pregnancy. Which should be discontinued before conception? Definitely 2 things we have to keep in mind. One is methotrexate, the second one is leflunomide. The other things are mycophenolate mofetil and cyclophosphamide. They have to be definitely discontinued before conception. There is no data on biologicals and leflunomide, but leflunomide has a role in hyperbilirubinemia. Hence, it has to be avoided 2 years prior to the conception. So biologics, regarding biologics, TNF-alpha inhibitors can be continued And effective drug treatment of active inflammatory rheumatic disease is possible with reasonably safety for the fetus during pregnancy and then lactation. What are the further research needed in this particular area of pregnancy and lactation? All the academic institutes should give the data to the public for access, whether the particular pregnant women or lactating women is on RA drugs. What are the long-term studies showing the results? This has to be accessed by each and every academic institution for their patients' benefit. Second one, long-term and international pregnancy registers have to be maintained and established so that we can assess the data and we can modify the course of action for our treatment. Then intensification of more recently licensed drugs and data collection. That is very mandatory to keep a track on biologicals because we don't have adequate data for biologicals, which has to be continued, which has to be discontinued. And country-wise pregnancy registers lead to the collaborative data analysis, which a country can formulate and adopt. And EULAR, definitely we have to consider EULAR guidelines, and prospective data protocol has to be followed. Along with that, a comparator group. Comparator group means nothing but disease matched women. If a woman is having RA, along with that, the same woman should have the matched individual should have the same RA. Along with it, whatever the systemic hypertension or diabetes. So matched comparator group comparison should be there between healthy pregnant women and non-exposed drug healthy pregnant women. So in this comparison, we can find out which group is getting good benefits. And finally, documentation of drug transfer from breast milk to the fetus has to be documented, and which needs further studies. In that particular area, we are lagging about the data on what biologicals have to be considered during lactation. So my take-home message in this lecture is management of rheumatoid arthritis cases during pregnancy and lactation is always weighing risk without holding treatment from the mother against any risk to the fetus. So mother has to be safe. At the same time, fetus should not get the disease or the side effects of the drugs which the mother is consuming. And the second one is restriction in use apply for the few proven teratogenic drugs and large proportion of medication which has insufficient data for the fetus and child are available. In this particular juncture, we have to think about a lot on biologicals, what to be followed, what not to be followed. RCT has to be conducted to see the clinical benefits and the safety of biologicals being followed in pregnancy and lactation. Thank you.
Thank you very much, Dr. Madan. You have taken further the work of Dr. Rameshwar. So fertility and pregnancy issues were definitely connected. So the teratogenic effect of a drug which is fairly established is leflunomide, and you have discussed about it in greater detail. Right.
This guy.
Dr. Chinmay, now it is your time. You have to discuss about whenever we are treating a patient, when to stop. So what is the likelihood of duration? So how long should treatment be continued is a real good question. Once remission is achieved, maintenance dose for longer period is recommended. Relapse occurs in 3 to 5 months, 1 to 2 months in case of methotrexate. Should it be discontinued in such instances? DMARDs are discontinued by patients because of toxicity or failure of response, which is common after 1 to 2 years, and such patients might have to be seen differently over a period of 5 to 10 years. Disease flare may require escalation of DMARD's dose and the dose of steroids. So, Dr. Lahkar, Professor Chinmay, you start your talk now. You are not audible. I will stop share. Yes. You are not audible. Yes. Your audio is not there.
Now you can hear me, sir?
Yes, yes.
Okay. Thank you. So, good evening, everyone. So, I'm going for this topic as duration of treatment with DMARDS. So, before going for the the duration of the DMARDS, so let us see. Just a minute, sir.
You are full screen already.
Full screen mein hai. I want
Yes,
to reduce the size of the screen actually.
No, why should you? Okay, there is overlap on the other
Overlap ho raha hai, sir.
end. Still you continue with it. Maybe few letters you will not be able to see.
Okay, sir. So approximately 10% of the patients, they respond, usually the seronegative patients, and there is a remission within 6 months. And but the vast majority, around 90% of the patient will exhibit a
You put off your video.
persistent and progressive.
Your voice is again breaking.
Sir, I'm not audible, sir.
Now you are. Now you are.
Now you can. Now
very,
you can see.
very clearly.
Listen, hear me, sir.
Yes.
Okay, so minority of the cases will have intermittent and recurrent explosive attacks, means flare-ups in the arthritis, and which they are interspersed with your periods of disease quiescence, disease silence. Disability as measured by the health assessment questionnaire is, it shows that gradual worsening of the disability over time in the face of poorly controlled disease activity and disease progression. And this disability, it may be related to the disease, that means the inflammation of the joints, which is potentially reversible with therapy, as well as it may be related to joint damage, which is potentially not reversible or irreversible due to the damage in the soft tissue, damage in the cartilage, damage in the bone. So early in the course of the disease, the extent of joint inflammation is the primary determinant of the disability. So there is only joint inflammation, which can be, which is in a reversible phase. But later on in the disease, when the amount of damage is more to the soft tissue, to the cartilage, to the bone, then it becomes the dominant contributing factor for the disease as well as for the remission which is achieved by the DMARDS. So the clinical disease activity with rheumatoid arthritis reflects the overall burden of the inflammation and is the variable that most influences treatment decisions. That when you are using single drug, when you are going to use dual therapy, when you are going to use these biologics or the biosimilars. So all depends on this, the overall burden of the inflammation of the joints. And this joint inflammation is the main driver of the joint damage and is the most important cause of functional disability in the early stages of the disease. So there are some indices which says these are composite indices to assess clinical disease activity, like the ACR 20, 50, and 70 improvement criteria, which actually correspond to your 20, 50, and 70% improvement respectively in the joint counts, the physician's or the patient's assessment of the disease severity, the pain scale, the serum levels of the acute phase reactants like your CRP and the ESR, the functional assessment of disability using a self-administered patient questionnaires. So we are also trying the IOA actually is also trying for a questionnaire, developing a questionnaire for our osteoporosis patients for diagnosis of osteoporosis. Then there is the disease activity score, the DAS score 28. There are 28 points, 28 joints means which gives rise to your DAS score. Then the simplified disease activity index, the SDAI, the CDAI, the clinical disease activity index, and the rapid 3, that is rapid routine assessment of patient index data 3. These are continuous measures for your disease activity. So based on these indices, we can go that when we have to go for a lower dose, when we have to go for a maintenance dose, or when we have to increase the dose, or when we have to go for dual therapy or multi-drug therapies. Coming to glucocorticoids, already all the speakers, they have said about these glucocorticoids. These are actually wonder drugs. So they control the disease activity when administered in low to moderate dose to achieve rapid disease control before the onset of fully effective DMARDS. Because even the anchor drug, the methotrexate, which is nowadays called the anchor drug, and which is recommended by EULAR, the EULAR guidelines of 22 last year only. So they said that methotrexate is the anchor drug and is to be included in all treatment of rheumatoid arthritis. So even these drugs, methotrexate also takes around 1 to 2 months, 2 weeks to start its function, to get its full potential. So during this time, we can go for glucocorticoids. Then chronic administration, as Jha sir has already said, that chronic administration in low dose, less than 5 or 5 to 10 milligram of prednisone can be used to control the disease activity in patients with an inadequate response to DMARD therapy, but it is to be avoided at best. Those glucocorticoids, we can consider intra-articular injection of intermediate acting like your triamcinolone acetonide as bolus dose for to keep down the inflammation in the particular joint as a local therapy. So coming to conventional DMARDs, synthetic DMARDs. So we have got already, we know that hydroxychloroquine, sulfasalazine, methotrexate, leflunomide. The initial evaluation for hydroxychloroquine, it should be eye examination. If more than 40 years of old, then sulfasalazine, you should have a baseline CBC and liver function. Most of these drugs, they are excreted by the liver as well as the renal kidney, the roots. And these should have your baseline evaluation of your renal function as well as the liver function, and monitoring of the optical coherence as well as CBC routinely at the interval of 4 weeks or up to 3 months. Means 1 month to 3 months, you have to go for CBC, then the renal function as well as liver function tests. Anti-TNF alpha agents, these these needs tuberculosis screening, and that is a must for before starting these drugs, because any latent tuberculosis which is so it can flare up during these therapies. And again, you have to have the liver function test that is to be periodically done. And these drugs, anti-TNF, these DMARDs, these are actually, they have got your allergic reaction or hypersensitivity reactions. And for these things, we have to monitor the injection site reactions by giving PPD in these doses. And then you have got abatacept. Again, the doses already, you need tuberculosis screening prior to starting these drugs, as well as the monitor your infusion reactions. Then coming to other interleukin agents like your anakinra, the rituximab, which is a wonder drug. But all these also interleukin inhibitors, you need to have your regular CBC investigations and your liver profile as well as your renal profile. Then comes your targeted synthetic DMARDS. These are JAK inhibitors. We know tofacitinib, upadacitinib, and baricitinib. So again, these drugs, you need a proper tuberculosis screening beforehand for initial evaluation, as well as you have to go for monitoring with CBC, LFTs, and lipid profiles. So there are some guidelines where you are using these are recommended, as already Jhasar has told, that from in modern means MH DAS score. If the scoring is too high, then adjust the disease modifying rheumatic drugs, anti-rheumatic drugs, sorry, at least 3 months until reaching low disease activity. So there is a new term introduced, treat to target, T to T guidelines. It was recommended in the year, I think 2015, 14 and 15. So they advise that adjusting the DMARDS in response to moderate to high disease activity scores within 90 days was associated with a shorter time for low disease activity scores. So your disease activity gets under control if you modify or if you add these DMARDS within the first 3 months of your initial therapy. So these are some of the literature which support these activities. These are published in 2012, 2014, as well as 2018. Sorry, the first one was 2018. So with this, I thank you all for your patient hearing. Thank you, sir.
Thank you very much. You have very clearly stipulated that what should be the various considerations when the duration of therapy should come to an end, if at all it is there. Well, Dr. Ranjit, are you ready with your presentation? You are muted, Dr. Ranjit.
Yes, sir.
Yes, can you proceed with your presentation?
I'm trying, sir. I'm not.
Okay,
that is the problem.
In that event, we will proceed with the next one. Next is Dr. Arul. Arul, are you there?
Yes, sir.
Yes. So, yes.
Sir, Ranjit sir has shared his screen, so let him present, then I'll present.
So
Ranjit,
probably you are
okay.
able to see my presentation, sir?
Oh,
Yes,
yes. Go ahead, go ahead.
So
Now slide show, you have to press slide show on the top in the red banner.
Sir, let him present in this only, sir.
Okay,
I think
go
he
ahead.
will have difficulty.
Ha.
Ranjit ji, you present in this only. No problem.
Red band में ऐसे slide show है. Yes, we welcome our Secretary General, Dr. Naveen Thakkar. Dr. Naveen, are you there? We can see you.
May I start, sir?
Just a moment.
Okay, sir.
Dr. Thakkar, are you there? Dr. Thakkar, okay. He is not.
I'm here,
audible.
sir. I'm here.
Oh yes. So we might lose you again. We will like to have some address from your end.
Yes, sir. I'm here.
Please. Right from his operation theater. Now your theater is 2 years old or 2 years young.
So congratulations, sir, for such a wonderful webinar. And congratulations to all the faculty, and thanks to all the faculty on behalf of the Indian Orthopaedic Association, sir. Sorry, Dr. Ranjit Singh, for disturbing your presentation starting.
No issue. You continue. We are most welcome.
We are meeting at Bhagalpur again.
Yes, of course.
Okay, sir. Please continue. Please continue.
Right. Thank you
Please
very
continue.
much. Only one
Thank you,
thing
sir.
I have to tell you as Secretary General, that this is the youngest next gen team. So you will
Okay.
find everybody is so young, so enthusiastic, and really tuned into orthopedic rheumatology.
Fantastic, sir. This is because of your hard work and their
Yes.
participation, active participation.
And it's a teamwork. Dr. Manish
It's a
has
team.
also been, yes, Manish has
Yes,
also
team
been
always
there.
wins. Team
Right.
always wins.
Thank you. Thank you very much.
Thank you, sir. Thank you. Thank you.
Okay. Dr. Ranjit.
Okay, sir. May I start?
Yes, please.
Okay. Good evening, everybody. Sorry for inconvenience caused by because I'm not computer savvy. Sort of problem.
Straight.
So my objective of the what to do when patient is on biologics or DMARDS. And the objective is to enhance patient safety peri-operatively. That should reducing the risk of infection, because infection are bound to happen if patient is on DMARDS or biologics. That is the general perception. Promoting optimal wound healing. Apart from that, in-depth counseling of the patient taking biologics regarding a stoppage of therapy prior to elective surgery. That is very important. So, rationale. What is the rationale? Biologics are now widely used for treatment of RA, AS, juvenile rheumatoid arthritis, psoriatic arthritis, etc., etc. And that poses unique surgical risks. So, a staff involved in preparing for the patients for elective surgery need to be aware of the rationale for pausing biologics and the time scales involved for each therapy. Not only the doctors, the staff should also be well aware of that. Otherwise, something may go wrong. So, British Society of Rheumatology 2018, a statement on safety of biologic therapies encourages consideration of risks and benefits of pausing biologics. So, this is a study. So, what happens? TMAC factor mediates inflammation and modulates cellular immune responses. TNF inhibitors which we are using affects host defenses against infections. So there is high risk for development of post-operative infections and healing complication in patients undergoing surgery. That is a general perception, and that is the truth also. Of all the studies evaluating the biologic therapy, those investigating the between anti-TNF alpha agents and infection risks are numerous, the majority of which have focused on the first generation anti-TNF alpha. Although there has been some inconsistencies between the results from various analyses, the studies have found a significant association with TNF drugs in patients with increased infection with patients on TNF drugs with RA and a high rate of infections. With regards of rituximab, most recent observational data from US Corona Registry showed similar rates of infection in 265 patients receiving compared with rituximab compared with 739 patients on anti-TNF therapy. Next, the meta-analysis showed decreased risk of serious infection with rituximab as compared to anti-TNF alpha therapy. But general recommendation is to stop rituximab prior to surgery. TNF alpha inhibitors are to be stopped along with rituximab. Risk of infection are highest in first 6 months of treatment, and concomitant steroid use increases the risk of infection further. So there are broad recommendations. Biologics should be stopped 3 to 5 half-lives prior to surgery. For clean procedures like arthroscopy, etc., thrice the half-life. For high infection risk procedures like GI tract surgery, 5 times high. half-life. Stop biologics prior to dental extractions. Stop biologics prior to biopsies resulting in open granulation tissue. Do not stop prior to endoscopy, cystoscopy, or punch biopsy. For bloodless procedures like cataract surgery, you don't need to stop biologics. So, advice regarding stopping conventional like methotrexate, etc. Stopping conventional DMARDs perioperatively are not recommended. And wherever you are in confusion or dilemma, contact the patient's rheumatology consultants for specific concerns. Biosimilar biologics and JAK inhibitors and immune modulator like apremilast are to be stopped prior to surgery and start only after wound heals well. So there is a flow chart. Guidelines for management of interruption of biologic therapies for elective surgery in adults with rheumatoid and other diseases. So, is surgery elective? Yes. If the patient is currently treated with glucocorticoids, yes, minimize glucocorticoids. Consider deferring higher risk surgery for till the dose is reduced. If no, is the patient currently treated with DMARDs? Conventional DMARDs, continue. If on biologics, hold biologics for one dosing interval before surgery unless risk benefit is risks are more than benefits. Restart biologics 14 days after surgery. But in an emergency situation, proceed with surgery. Continue conventional DMARDs, restart biologics, stop biologics, and restart after wound 14 days or more after wound has healed. The commencement of biologics. Then after stopping, when to start? So recommenced around 14 days post-op or only if you are satisfied that wound has healed well. And condition, in your opinion, is good. Surgical site is the no sign of local or systemic infections are there. If you are sure of that, then you can start it. Usually after 14 days or more. So these are the general recommendations for different groups. I'm not going into it, but that is simply one dosing interval after next dose. Before the next dose is to be given, you plan your surgery. Thank you.
Thank you, Dr. Ranjit. You have rightly said that when you plan an orthopedic surgery especially, then what should be the different modalities? When should you stop them? And normally you have said for some procedures it should be stopped 3 weeks pre-op or 5 weeks post-op. The general formula we would like to remember always will be 4 weeks, 4 half-life before surgery for each drug. Now, for a emergency surgery that has come to your emergency OPD, you cannot modulate the stoppage because the patient maybe had his last dose only a day earlier. But luckily, it has been observed that in all the emergency surgeries, when it was not stopped 4 half-lives earlier, there has not been higher incidence of infection. But this is just a general observation. For planned surgery, you have rightly outlined everything. So thank you very much, Dr. Ranjit. Now I would request Dr. Arul Kumar. Dr. Arul?
Yes, yes, sir.
Yes, please go ahead with your presentation.
Sir, is it visible?
Yes.
Yeah. A very good evening to all, my dear teachers and colleagues. So now we are going to see something about the adverse effects and complications of conventional synthetic DMARDS. So basically, DMARDs are not analgesics and they doesn't inhibit the COX inhibitors. They works by suppressing the inflammatory process in conditions such as in rheumatoid arthritis and certain spondyloarthropathies. Basically, the response are unpredictable in the early phase of treatment. It takes a couple of months to achieve the therapeutic level. So it works by reducing the inflammatory markers, and in that way it helps in remission. So as a treating physician, we are at certain confusions on which DMRD to begin and which DMRD to begin for certain patients, and what is the clinical stage of those patients, and we have to assess the severity of the disease as well. So we have to know and we have to teach the patients regarding the possible side effects and expected benefits, and we have to consider the customization of the treatment should be done, whether the patient is a pregnant or he is going to conceive, or he is a young, or it is a old patients with any comorbidities, other medical conditions, and the personal experience should have been taken into account. So the most common side effects of the entire group of DMARDs are the loss of appetite, nausea, diarrhea, and abdominal pain. So these are all the common side effects that is encountered in a patient taking DMARDs for a month. It is 72%. It is reported in the literature that a patient is taking DMARDs in a month. These are all the common side effects that they have encountered. So the other common side effects were rash, allergy, hepatic ailments, and increased risk of infections, as already pointed out, and pancytopenia. So coming to the most common and the first choice DMRD, methotrexate, it has been started with the minimal dose of 7 milligram weekly dose. Everybody knows that the higher dose of 30 milligram daily, it was used in cancer chemotherapy. So it takes a time for clinical benefit is 1 to 2 months. It exerts anti-inflammatory pathway by inhibiting the DNA and RNA synthesis, and it works by inhibits the chemotaxis of neutrophils and decreases the production of pro-inflammatory cytokines by activating the T cells. So the most common...
Just a moment, please continue with the recording. Don't stop the recording.
Yes, sir. So the most common side effects include gastritis and the mouth sores. And as the mechanism of action is, it inhibits the DNA synthesis, and so that's how it inhibits the most proliferating and rapidly growing cells such as the blood cells. So the most common side effects were pancytopenia. So since it has reducing the leukocyte production, these patients are more prone for infection. Since it reduces the platelet counts, they are more prone for easy bruising and bleeding as well. As already pointed out, serial monitoring of LFT should be done, and the patients who are alcoholic are more prone to get hepatic ailments because the alcohol and this methotrexate has synergistic toxic effect over the liver, and on chronic methotrexate therapy, they are more prone for interstitial pneumonitis as well. Women should not become pregnant because they are categorized under category X drug, and they should be stopped this therapy at least 3 months before they are planning to conceive. So the current recommendation is the patient should get monitored for CBC, creatinine, LFT monthly for 3 to 6 months. Then every month they should be monitored. If the patient has been diagnosed with methotrexate toxicity, they should be managed with adequate hydration, and alkalinization of urine has to be done. And they should given a dose of 100 milligram per meter square of leucovorin. And recently glucoropidase, a methotrexate cleaving enzyme, has been discovered that can be utilized. If oligouric, then immediate hemodialysis should be advised. So the basic contraindications were the patients with acute hepatitis or any serial bacterial infections or fungal infections. They are all the high contraindicated patients, and the patients with the acute chronic renal failure with the creatinine clearance of less than 30 milligram per minute, and if they are planning for a pregnancy and a lactating woman. So patients taking methotrexate should take folic acids of 1 to 3 milligram daily, or a folinic acid 5 milligram weekly to reduce the above mentioned side effects. So here is the teratogenic effect of folic acid, methotrexate, which causes the multiple dysmorphic facial features. Coming to the next most common used drug, sulfasalazine, which is safer, that we can be used in pregnancy. So the most common side effects that we have noted with sulfasalazine are nausea, vomiting, diarrhea, headache. These are all the common side effects with the other group of DMARDs. But the specific side effects are the skin lesions, and those patients who are allergic to sulfa drugs and those who are taking Septron, that is cotrimoxazole, those patients are more prone for this sulfa allergy. And those patients who are having susceptible to G6PD deficiency enzyme, those are more prone for sulfa toxicity and allergy as well. So this is the lichen planus kind of soft tissue lesion in those patients. So how we are going to monitor the patients who are in sulfa drugs are the complete blood count for every 2 to 4 weeks for the first 3 months. Thereafter, every 3 months we have to take a liver function test for 3 months, then every 3 months. So the contraindications are those who have the elevated liver enzymes 2 times the upper limit of normal and the platelet counts of less than 50,000 millimeter cube, and the acute and chronic liver toxicity patients. So the third most common drug is the hydroxychloroquine. This is basically an anti-malarial drug which we are using for rheumatoid arthritis because of these immunomodulatory effects. It acts by inhibiting the leukocyte chemotaxis and suppresses T lymphocyte proliferation and traps the free radicals. So the starting dose is 400 milligram OD or with the maintenance dose of 200 milligram or 300 milligram, 400 milligram OD. The time for clinical action is 2 to 6 months. The most common adverse effects is it causes maculopathy. So the typical picture what we will see in the literature is the bullseye macula, and with the higher doses it causes neuromuscular weakness, cardiomyopathy with the valvular heart disease, and some kind of conduction deficits. So in sequential or serial ophthalmic examination should be done at least once in a year. These drugs are relatively safer during pregnancy. They can be used alone or in a combination with sulfasalazine or methotrexate to provide a synergistic effect. The fourth drug is the leflunomide. It acts by inhibiting the dihydroorotate dehydrogenase enzyme in the pyrimidine synthesis pathway, thereby inhibiting the T cell production, thereby inhibiting the synovial proliferation. So the dosage is 20 milligram per day, and it also takes the time for clinical benefit is 1 to 3 months. The most common side effect that what we are encounter is the weight loss and abdominal pain with the temporary hair loss and hepatotoxicity. The specific side effect is it has specific toxicity to the neuroglial cells. So the nerve damage may be the possible side effect. This is the case report showing a severe skin reaction after a leflunomide and etonerceptor in patients taking rheumatoid arthritis patient. In that case, they have demonstrated a skin biopsy showing a focal epidermal necrosis with partial lichenoid changes. So the patients with hypertension and increased cardiac toxicities are reported in 10% of the people. So testing for prior exposure to hepatitis and regular blood testing while on therapy are needed to monitor for liver damage and other toxicity as well. So women should not be pregnant. This is also a category X drugs as mentioned by Dr. Madan. So the monitoring is every 2 to 3 weeks, complete blood counter should be there for first 3 months, then thereafter it should be taken every 3 months. And the highly contraindications are patients with acute hepatitis and with serial bacterial infections and with creatinine clearance of less than 30 milligram ml per minute, and patients planning for pregnancy and lactation. So the last but not the least, the penicillamine drug, it acts by several mechanisms including metal ion chelation and dissociation of macroglobulins. But we are rarely using these drugs now because of the nephrotoxicity of this penicillamine drug. It can cause the immune complex mediated glomerulonephritis and heavy proteinuria. So these are all the second line of drugs for this rheumatoid arthritis. And gold salts, it acts by inhibiting the monocyte chemotatic factor and additionally alters lysosome enzyme activity and reduce histamine release from the mast cells. So the possible side effects are dermatitis, proteinuria, blood dyscrasias, hepatitis, peripheral neuropathy, and finally aplastic anemia, which will be fatal. Azathioprine, basically it is not a synthetic conventional DMARD, it is an immunomodulator. It acts by the immunomodulating activity, it's same as that of methotrexate. Its use in rheumatoid arthritis has been less frequent in nowadays because of the possible side effects and more availability of other useful DMARDs. This possible side effects would be nausea, vomiting, and liver function abnormalities, and leukopenia and infection. So the take-home message is before treatment begins, the patient clinician should discuss the benefits and risk of each type of therapy, and include possible side effects, toxicities, dosing schedule, monitoring the frequency and expected results, whether to include biologics or whether to initiate some conventional DMARDS first, then when to start biologics, like that. So certain screening tests, including the screening for tuberculosis and including the blood test to assess the hepatic functions prior to start therapy. Complete blood count should be mandatory. So the prompt recognition of adverse effects help us to manage the condition in a timely and good manner. Thank you.
Thank you, Dr. Arul.
Thank you, sir.
So you have extensively talked about the conventional synthetic DMARDs, and you have brought out the various complications associated with. I would like to highlight a condition which goes by the name of DRESS syndrome. This is a drug reaction with eosinophilia and systemic symptoms. This syndrome is a potential life-threatening form of cutaneous drug adverse reaction. The severity of the syndrome is related to the systemic manifestations, which can result in multiple organ failure. So we should be conscious of this one also. Now, next, Partha, you have to speak on DMARDs regarding contraindications of their use. Dr. Partha, are you there?
Yes, sir.
Please go ahead.
Please allow me to share my screen.
Yes, you can. Right.
Thank you, sir. I'll please excuse me, sir, for the background noises and my surrounding, because I had to leave for a flight. So I'm on the way, actually.
Okay.
Sorry for the inconvenience. The contraindications of DMARDs, actually, most of my esteemed previous speakers have already, in a subtle way, included some parts, and we already have an idea of mainly during pregnancy and lactation that has been extensively discussed already. So I'll just wrap up the things. Okay, so coming to the methotrexate, most of the DMARDs, if there is a history of hypersensitivity, so that is a contraindication. Pregnancy, as we have already discussed, and breastfeeding, methotrexate is contraindicated. Certain coexisting diseases which we should be very cautious, like blood disorders, bone marrow hyperplasia, lymphopenia, thrombocytopenia, and other forms of anemia. In that cases also, we have to be very, very careful before starting methotrexate. Chronic liver disease, because methotrexate itself causes hepatotoxicity. Other forms of liver disease, cirrhosis, alcoholic hepatitis, alcoholism, all are relative contraindications again. Immunocompromised states like HIV/AIDS, some blood dyscrasias, and renal dysfunction, and also radiotherapy. These are also relative contraindications. We have to be very cautious with methotrexate because it interacts with so many other drugs also. It is highly plasma protein bound, so any other drug which is also protein bound displaces methotrexate, so increasing its serum concentration. Any drug which has effect on the renal clearance, it will also affect the toxicity and the serum levels. Then NSAIDs, salicides, then penicillin, warfarin, all these drugs also have a risk of increasing the toxicity of methotrexate in the blood by increasing the displacing the methotrexate from protein bound and also modulating the renal clearance. Aminoglycoside, neomycin, probenecid also reduce the absorption of methotrexate. Coming to the next drug, there is HCQ, hydrochloroquine. It is contraindicated if patient is already having visual or retinal field changes. Again, hypersensitivity to aminoquinolines is a relative contraindication for hydroxychloroquine. Liver function, again, because it causes hepatotoxicity. And during this COVID time, we came to know, and it was very much highlighted, this QTC interval prolonging risk. And so this should be taken care of. It's mandatory to take ECG before starting hydroxychloroquine. It can also increase the bleeding risk if the patient is on anticoagulant therapy. And some other drugs like co-administration of hydrochloroquine, it is said that it reduces the threshold for convulsions. So we have to be careful. Coming to leflunomide, again, hypersensitivity is a contraindication, pregnancy is a contraindication. Liver toxicity, it has liver toxicity, so severe liver injury, again, is a contraindication. And it is never also not recommended for patients with severe immunodeficiency, immune dysplasias, or uncontrolled infections. Sulfasalazine, mainly it's group-specific hypersensitivity to other salazine products and sulfonylureas. And intestinal or urinary obstruction is again a relative contraindication. Porphyrias, patient having porphyrias are contraindicated. Coming to the biological DMARDS, the first line, there's anti-TNF alpha drugs. Active or latent tuberculosis, any form of other infections, also any viral hepatitis, these have to be ruled out. You cannot start patients on any infection within biological DMARDs as per se, group specific. And again, it is contraindication in lactation also. Coming to interleukin-1 blockers, same, any infection, any neutropenia, you cannot start. And lactation, again, it is contraindicated. Tocilizumab, interleukin-6 blockers, it is diverticulitis as a contraindication. It is said to cause intestinal perforation. So patients who are having history of diverticulitis, there is a relative contraindication of interleukin-6. Also, interleukin-6 blockers have been shown to have a bad effect on people who already had COVID infection, or in the very, like, who are already compromised with COVID infections. So coming to JAK inhibitors, tofacitinib, and these infections, again, same infections, hepatic failure, renal failure, and in pregnancy and lactation. So to sum up, any latent infection should be ruled out for starting before any DMARDs, especially if we are going for the synthetic DMARDs, methotrexate, we have to rule out so many things. We have to rule out pregnancy, we have to rule out organ dysfunctions, we have to rule out neutropenia. Same for the biological walls also, and especially in females, because in reproductive age females, we have to be very careful planning for pregnancy, planning for lactation. If there is, and we have to tell the patient, counseling the patients very well, that even if you are planning, you have to tell or inform us way before, so that we can effectively change the drugs. Then again, on patients on DMARDs, there is a chance of opportunistic infections. So that should be kept in mind. That should be checked again and again. And in some cases, like some patients might have chances of varicella infection, herpes infection. So they should be vaccinated before the pre-treatment started. So that, I think, sums it up. Thank you.
Right. Thank you, Partho. Now I will request next speaker, Dr. Vishnu Senthil. Dr. Vishnu, you are there?
Yes, sir, I am there, sir.
Right. So go for your presentation on tuberculosis and opportunistic infection.
Sir, you can see my slides, sir.
Right, very clear.
Yes. At the outset, I like to thank the Indian Orthopaedic Association, IORA, and Professor Jha sir and Professor Manish Khanna sir for giving me this opportunity to talk on relevance of DMARDS in suspected tuberculosis and evolution of opportunistic infections. So coming to the introduction, as my previous speakers spoke, DMARDS are commonly divided into biologic DMARDS, conventional synthetic DMARDs, and the latest Janus kinase inhibitors. These Janus kinase inhibitors are generally, they cause aberrations in the T cell range and reduce the capacity of new T cell lymphocytic generation, and also they by regulating the cytokine signaling pathway. So coming to the why does tuberculosis and opportunistic infections are mainly common in these type of biologic DMARDs. So TNF alpha is the main immune mediator which helps in maintains the formation and function of the granulomas. They increase the phagocytic response of the macrophages and enhance the intracellular killing of the Mycobacterium tuberculosis by generating the reactive oxidants, and these oxidants help in destroying the bacteria. So next also the interleukin 12, the 17 and interleukin 23 are necessary to contribute to the cellular responses of and help in generation of the interleukin IFN alpha and the TNF alpha. So coming to the conventional synthetic DMARDs, the best safety profile is with the HCQs and the sulfasalazide, and many literature reports are supporting that methotrexate causes opportunities infection and also helps in developing involving latent tuberculosis infection to exuberant tuberculosis infection. So coming to the TNF inhibitors, the least risk is the etorancept, and the highest risk for the developing opportunistic infections is the infliximab, and highest risk is less than 6 months of therapy. So these are the commonly used is the infliximab, which has the highest risk of the opportunistic infections. So next is the CTLA4. The abatacept is the first generation which is approved for rheumatoid arthritis treatment. Coming to the interleukin 6 inhibitors, the tocilizumab, which is commonly used, is a potent interleukin 6 receptor inhibitor, and there are reported cases of severe zoster and Epstein-Barr virus and zoster reactivation and formation of abscesses. So coming to the Janus kinase inhibitors, the tofacitinib and the baricitinib are in the market, and the upadacitinib are yet to be come. So coming to the tuberculosis, the incidence of tuberculosis in rheumatoid arthritis patient has more 2.28 fold than the normal population, and the rheumatoid arthritis patients receiving the anti-tuberculosis TNF therapy have an increased 10.1 to 35% fold increase of developing tuberculosis in comparison to the normal population. Coming to the in the rheumatoid patients, there is a nearly 30% risk of developing the pulmonary tuberculosis, and next is 8.5% is the disseminated tuberculosis. Next comes the peritoneal tuberculosis, the pleural tuberculosis, and the bone tuberculosis. So coming to this slide, and we can see in this slide there is a maximum increase or slightly higher risk in interleukin 6 inhibitors, which is mostly the tocilizumab, which has high risk of developing opportunistic infections, and along with combined with high dose glucocorticoids increases the incidence of tuberculosis and opportunistic infections. Coming to the tumor necrosis factor inhibitors, the abatacept has the lowest risk of opportunistic infections, and also the infliximab has a little more risk than the abatacept. So coming to the Janus kinase inhibitors, which has also similar risk demonstrated to the tumor necrosis factor inhibitors. So the rituximab, the CD20, has a light or similar lower possibility of opportunistic infection risk in the tumor necrosis compared to the tumor necrosis factor inhibitors. So coming to the most common opportunistic infections, in the bacterial, we can see the tuberculosis, the listeria, and the invasive legionella. And coming to the fungal, we can see the most common is the pneumocystis jirovecii pneumonia, the cryptococcus, the aspergillosis, and the candidiasis. And in the protozoal, we can have the toxoplasmosis gondii and cryptosporidial, and leishmaniasis is demonstrated in the opportunistic infections. The herpes zoster, the most common, is localized and rarely is disseminated, and it's most common when we give accompanied with glucocorticoids, that is systemic high dose glucocorticoids. Rituximab has highest risk of hepatitis B virus and also few cases of progressive multifocal leukoencephalopathy has been demonstrated. Coming to the grade summary compared to the placebo, the mycobacterial opportunistic infections has a high grade evidence compared to the viral and the fungal, compared to the viral and the fungal. So all others have the moderate amount of evidence in compared to the mycobacterium tuberculosis, which has a high grade evidence of opportunistic infections when using these biological drugs. So coming to the prevention, the most common is the mycobacterium tuberculosis, which is mainly can be prevented by the anti-tuberculous drugs. And in other bacterial infections, which are next common is the Listeria monocytogenes, which is most common when using the methotrexate and the infliximab, and which can be treated with ampicillin and the sulfamethoxazole and trimethoprim. Coming to the next is the Legionella pneumophilia, which is airborne, which is common in methotrexate and infliximab, which can be treated with fluoroquinolones and macrolides. So coming to the viral, the most common is the varicella zoster, which is disseminated, and also the herpes simplex virus, which is common in methotrexate, anti-tumor necrosis factor therapy, and also in infliximab, which can be treated with antivirals by acyclovir and other group of advanced group of antiviral drugs. So next is the fungal, which is the pneumocystis carinii girovesi, which can be treated with sulfamethoxazole, which is mostly common airborne, and also the candida infection, which is common in immunosuppressive drug or the immunomodulators with the methotrexate and infliximab, which can be used by antifungals, the fluconazole. And in the parasitic division, the Toxoplasma gondii disseminated, which is common by using treatment with methotrexate and with infliximab, and which can be treated with sulfadiazide and pyrimethamine. So these are my reference articles, which leads to opportunistic infections and tuberculosis, which can develop in biologic anti-rheumatoid drugs or the DMARDS. So in conclusions, biologics have increased the incidence of tuberculosis and opportunistic infection, but more data and more studies are needed to establish their relationship. Thank you.
Right, Vishnu, you have done a tremendous in-depth discussion into various kinds of opportunistic infections, and you have also dealt with the tuberculosis as well. So right. So now all the topics are open for discussion. Dr. Manish, Professor Manish, Professor Mazumdar, Professor Rajesh, and everybody should continue the discussion, please.
Thank you so much, sir. I think the boys have done a wonderful job with presenting in depth all these topics. There are a few points which I want to discuss. First of all, I'll want to have a discussion with Dr. Rameshwar. Are you here, Dr. Rameshwar?
Yes, sir.
Rameshwar, unmute here. Can you again elaborately describe once again hydroxychloroquine in male and females while planning for a baby in a concise form?
Sir, wait a minute.
You very well explained in the females it should be safely taken.
No, sir. Actually, as I have said that only few data are available about the hydrochloroquine, and the safety profile is very good about the hydrochloroquine. So it should be continued, and it is recommended for the treatment.
For both males as well as the females.
Yes, sir. Yes, sir.
Correct. Secondly, Dr. Arul, you were telling about the methotrexate. What is the optimal period of initiation of the action of methotrexate, whether oral or injectable? So according to what I feel, it is still 2 to 3 months, and you have mentioned 1 to 2 months. So have you seen any recent literature in which you encounter that it is acting in 1 or 2 months of time? Usually take 2 to 3 months at least.
Yes, sir. They have mentioned like it takes like 6 to 8 weeks of period, and it is also based upon the like pharmacodynamics of each and individual. So they are given in a wide range only, sir, as you said.
What is your intake, Professor Jha, sir, for methotrexate onset of action?
Yes, to be safer, it should be 3 months. But there are observations that some pregnancies have continued not with methotrexate while the patients were on sulfasalazine. And so it has rightly been observed that sulfasalazine can continue safely in pregnancy.
So
But the
that's why
same,
before conception, they are telling minimum 3 months, there should not be any methotrexate. Because
Right.
methotrexate action will be there, T-half will be there for minimum 3 months.
That's
what I understood.
Yes, here itself I would like to say that tubal pregnancy, it is the gynecologist's drug of choice for killing that fetus. So that is the kind of relationship between pregnancy and methotrexate.
Yeah,
So
perfect.
3 months would be safe, right?
Correct. And Dr. Arul, you were describing about leucovorin. Is it available in the market to be given?
Sir, it is available, sir. Basically, we are not giving leucovorin, but the oncologist, those who are giving methotrexate for some other indications, they are giving leucovorin along with the chemotherapy drugs. Not only for methotrexates, they are prescribing for other chemotherapy drugs as
As
well.
an orthopedic surgeon, we are not using it at all. Actually, we don't have that indications.
But this is a good information to have that anti-methotrexate drugs are available and can be used.
Perfect.
But
Right.
as it has been shown rightly, that if by chance pregnancy has been there, it must be aborted, terminated.
Correct.
Yeah, medical termination of pregnancy has to be done.
Right.
Correct. So a proper counseling is very important before starting these
Yeah.
drugs. Right. Thank you. So this from my side, Dr.
Sanjay is there?
Can I,
Yes,
sir?
Dr. Rajesh, yes, please.
Gupta, sir. Yeah.
Yeah.
Sanjay is
Sorry
actually
for that late,
doing a
sir.
meeting with
Informed
the
you.
DGHS.
Okay, Rajesh.
Sanjay is busy with
Yeah.
the DGHS meeting.
Okay.
Yeah, Vishnu, regarding the infections, you say when an infection is there, you have to treat the infection part, right? But
Yes,
what
sir.
about the DMARDs and biologics? Have they been stopped, or we have to change that? DMRD or some biologics. Vishnu is here.
Yes, sir.
So question is, you understand the question?
Yes, sir. Whether we have to discontinue the biologics
Yes.
or DMARDS when we are having opportunistic infection.
If you encounter the infection, we are treating the infection part, all right. Are you
Yes, sir.
stopping the drugs? Are you
Actually,
changing the drugs?
sir, actually, in articles, I have not found any literature regarding whether they have stopped any drugs, sir. They have just mentioned that because of these drugs, these opportunistic infections may be caused, but they are not directly related. It is might due to any immunosuppression that these opportunistic infections are there, sir.
Dr. Jha, sir?
But in EULAR guidelines.
Yes.
Within EULAR guidelines, I came across methotrexate alone can be stopped till active infection is subsiding.
Yes.
Once it is subsided, methotrexate can be started. This I have read in one article in EULAR guidelines.
So the best would be to just continue with the hydroxychloroquine or sulfasalazine. It's a safe play for all the places.
Yes.
And for methotrexate, again, yes. And for biological, definitely, it should be thought that it can be stopped for some time.
Let us take it the other way around also. Suppose in a planned surgery case, we contemplated the surgery only after 4 half-lives earlier the drug was stopped. And still we counter post-operative infection or surgical site infection. In that event, we don't have to start all the DMARDs that was there, but for the drugs that Dr. you have said right now?
Sulfasalazine,
Madan, yes. So sulfasalazine would be safe, even methotrexate can be continued.
So when we talk of, sir, folic acid, there are different versions, in our clinical practice. Some people are giving twice weekly, some are giving daily, 1 milligram or 5 milligram. What is the take on that?
There are various kinds of opinion. Previously, it was said that if the patient is on methotrexate, folic acid at least should not be given on the day on which methotrexate is being given. But now people say no harm. It can be given the same day also. And as far as the dosing is concerned, the minimum that can be given is only once. Some people prefer giving it twice, some people prefer giving it daily. So all kinds of opinions are there. Dr. Chinmay, Professor Chinmay, you will throw some light on it? Professor Chinmay, are you there? Yes.
He is not there.
Okay, fine.
Sir, there is a commercially available kit in the market called Mex kit. In that if you take the first day drug, that will be methotrexate.
Oh, yes,
Then
yes.
from the rest of the 6 days will be folic acid. And again, 8th day will be methotrexate. And 9 to 14 will be folic acid. So
that is maxed F.
coming in the commercial
That is
kit.
maxed F 7.5 kit.
Yes, sir. Yes, sir. Mex kit.
But
It is 1 gram
because
or 5 gram? 1 gram or 5 gram?
That is 5 milligram.
5 million.
See,
But
actually,
For 6 days in a week.
yes.
folic acid main aim is to minimize the GIT and related toxicity of the methotrexate. So if the doses of methotrexate are of higher side, suppose you are giving 15 milligram once a week or 10 milligram twice a week, then you need to have a little bit more folic acid. Otherwise, the GI symptoms will appear. So practically, there is no thumb rule for this. As you increase the dose of the methotrexate, you have to think over for folic acid supplementation. And it is always better to have it. Sometime, the pancytopenia has been there and it has been reported by giving folic acid, the side effect has been reduced. So there's no thumb rule to control to clinical practice. It can be varied, but definitely in my clinical practice, I always accompany folic acid most of the time when I'm giving more than 10 milligram twice a week. So folic acid is 3 times a week at least. And I feel very safe for that.
Sir, I think even if we give a higher dose, there is no harm.
No harm.
That is what I do is I give weekly methotrexate, and for 6 days it is folic acid. That is what I practice.
Mex kit, whatever
Yeah,
I
it
am
is
following,
same,
also
but
the
yeah,
same.
whatever. So we practice
Yes,
the
sir.
same.
Traditionally, but you should not give it on the day that you are giving methotrexate.
Methotrexate.
Yes,
But
sir.
now people are not obeying this rule also. Right.
Sir, I have also few questions.
Yes.
First is for Professor S.S. Jha, sir.
Yes.
Sir, as it was mentioned by you, the conventional therapy in a patient newly diagnosed with rheumatoid arthritis has to be started with methotrexate or methotrexate. Other alternative is HCQS plus or sulfasalazine. So when it comes to the next step, when the patient is not responding, it is like converted to a dual therapy and later on to the triple therapy.
Right.
So question is, what are those drugs which will be using for the dual therapy in those cases, and next the same thing for the triple therapy. So what will be those
I'm
combinations?
very happy you have used the dose word. I personally feel that when we are talking of Indian patients, the body weight of Indian patients are lower than Western patients. So especially when we are using biologics, I say use half the dose, and I have used in more than 2,000 patients etanercept, and that I have used only in half dose, that is 25 milligram weekly. Now, coming back to the drugs that you want to know, methotrexate is the seat anchor drug. And the dose that I always prefer is 15 milligram minimum weekly. I never go by 7.5 or 10 milligram, and will naturally be supplemented with folic acid. And if the patient has psoriatic arthritis, I will even go for 25 milligram weekly, might reduce it to 20 milligram, but in psoriatic cases, I keep it at a higher level. As far as sulfasalazine is concerned, because of the likelihood of complications, I always again feel that dose is very important. So I have not used in almost 90% of patients, more than 1000 milligram daily. That also, when I will start the treatment initially, and it is also recommended, start with 500 milligram for few weeks and then switch over to 1000 milligram, or 500 milligram morning, evening, and then 2000 milligram. My standard practice of using is 1000 milligram daily.
And this, for the triple therapy, sir?
I am not very much in favor of triple therapy. If I feel that combination of two drugs have not given the adequate result, I would better switch over to one of the biologicals. And the first biological that I prefer is etanercept. Sometimes, yes, even adalimumab. That's it.
And how about, sir, SCQS, the dosing, how to start with if suppose we are combining it with methotrexate?
Well, if I can say so, hydroxychloroquine, always start with lower dose, 200 milligram. Now, since last so many years, 300 milligram is available. Yes. I would always recommend that use it in the night because of the photosensitivity that is it causes if it is given during the day, and take the medicine along midway through your food. This gives you a better analgesic effect. And number 3, I have a different personal trick in using it. If my patient says, I will always ask about bowel habit of the patient. If my patient says, doctor, I am a chronic constipator, I will definitely use hydroxychloroquine. So if the patient has been on hydroxychloroquine, invariably the patient tells me, what drug you gave me? Perhaps this is one anti-constipation drug, which actually it is not. But this is one of the tricks I follow.
So yeah, very you prefer sulfasalazine over hydrochloroquine with methotrexate in combination.
Yes. What did you say? I could not follow.
So usually you prefer sulfasalazine with methotrexate for combination therapy.
I will tell you, we orthopedic surgeons are invariably getting patients of more spondyloarthropathy than rheumatoid arthritis. Wherever the spine is involved, though there are no direct claims of its effectiveness on the spine, but it is universally accepted that it really works on the axial skeleton, also on the peripheral skeleton. Hence, you will find invariable number of times in my prescription that I prefer using sulfasalazine. One disadvantage with sulfasalazine is normally what it should have done to the bowel habit, it should have regulated the bowel habit. But because of some manufacturing problem, some patient will say, I take sulfasalazine and I have to run to the toilet. I have probed the manufacturing process in the factories, and I have found that the sulfasalazine is a drug which almost has a khaki color. So this factory is very separate because everything gets colored, including the walls, etc., etc. And there are some sets of medicines which are produced are having this bad property of multiple stools, multiple defecation problem. So if a patient complains to you that I'm having more movement of bowel, you ask him to change the batch.
So my next question goes to Dr. Madhan, related to his presentation, and I feel the panel should be able to clarify me on that. Suppose a couple is there and he's planning to conceive, and then they are already on conventional DMARDS, which need to be stopped by virtue of the information which we have got with regard to the damaging effects during pregnancy. So what should be the duration before we should advise them? Like, because we often get the references from gynecology department that since patient is having multiple joint involvement, known case of rheumatoid arthritis on DMARDS, so patient is planning to conceive. So give us some opinion regarding the stoppage of these medications. So what should be the duration before the actual conception is advised to these couples who are taking DMARDS? Of course, we know that sulfasalazine and SCQS can be continued further, but in case, if suppose patient is on methotrexate and other
If it is
drugs.
a female, if it is a female.
Yeah, sure, sir, female.
Yes, this is already explained in my presentation. Once again, I'm telling this, methotrexate has to be discontinued at least 3 months prior to the conception. So if a pregnancy is planned 3 months prior to that planning, they have to stop methotrexate. And they can continue very well regarding HCQs and sulfasalazine, which is a very safe drug during pregnancy. If needed, low-dose glucocorticoids 10 milligram per day can be taken if the disease is having minimal inflammatory reaction. If the inflammatory reaction is more, then you can step up the dose of glucocorticoids.
Dr. Madan, there is the issue of the use of folic acid with methotrexate. And the pregnant ladies, they are supposedly being advised to use the folic acid to prevent the neural tube defects in the fetus. So can you enlighten like as to how to go about this part to be taken care of? Of course, I have understood that we have to stop methotrexate 3 months prior to it. So can you just
normal pregnancy
with regard to the deficiency of folic acid which has been created in the body, so something is significant in that regard or to be done in this regard?
Yes, we can continue a folic acid, which is of no harm. And during a normal pregnancy, 1 month prior to the planning of pregnancy, they will start folic acid. Usually, it will be continued for minimum 100 days they have to take. But in regards to methotrexate, if it is stopped for 3 months prior to the planning of pregnancy, yes, you can continue with folic acid. There won't be any harmful effect because of the folic acid.
Because it's a very serious issue these days about the neural tube defects in children because of
it is recommended that if the patient is on methotrexate and you are planning for the surgery, if you are stopping the methotrexate, then you must be continue folic acid therapy. It is shown in studies.
Okay.
Sir, my question to Jha sir, please.
Yes.
Some of the patient of RA comes with renal diseases like creatinine 2 or more than 2, and diabetes mellitus, means sugar about 200. Then what should be the bridging therapy? We just can't prescribe steroid because of diabetes, and we just can't give NSAIDs because of raised creatinine level. Then what should be the bridging therapy?
Right. Number one, somebody very rightly said, if the patient is diabetic, hand over the patient to a diabetologist. And if you have to prescribe steroid, do prescribe steroid and counterbalance it with anti-diabetic drug. This is one. Second, if the kidney has been involved, the safest drug to be used are targeted synthetic ones, the tofacitinib or the baricitinib, because EGFR, even if it is up to 30, you can use them. So I think in such a situation, the breathing therapy will have to be combined with targeted synthetic drugs.
Why can't we use HCQs in this regard, sir?
Oh yes, you can
We
go
can
with
continue HCQs as
you
well.
can,
Now.
you can.
But the
Yes,
effect
sir.
comes after two months, na? Then I'm talking about bridging therapy, whether it should be NSAIDs or not.
So
If the creatine level is 2.
no, don't go for creatine. Then go, as I said, give steroid, counterbalance it.
Okay.
Actually, Dr. Ramesh, I think I previously many times told everybody like there is some drugs like Rosiflex, herbal preparation. They are very strong anti-inflammatory and they can be very well accompanied. I always give them rather than to going for a glucocorticoid and then going for a
Balancing it.
hypoglycemic. That's a very important thing. And in all these cases when the renal involvement has been there, you have to reduce the drug. You need not to stop the drug. Even hydroxychloroquine, sulfasalazine. Even I was just hearing few minutes back, sulfasalazine. Sometimes I even use 1 gram BD. So it can be given till 2 grams. For example, in some spondyloarthropathic cases, I've seen the results to be there. I'm a very old-fashioned, still using a DMRD, and Dr. Sharat Agarwal was asking about the pattern. So Dr. Jhasar, I still use hydroxychloroquine, methotrexate, and sulfasalazine.
Yes, yes.
And it works very well. The first drug is methotrexate. Second add-on is sulfasalazine. Third add-on is hydroxychloroquine. It works very well. And because I always say, whenever I take these lessons to the fellows also, think every patient as your own family member. If our family member are going to have a rheumatoid arthritis, we are not going to start biological because biological are the weapons which should be used when it has to be used. So we should give a full trial to one or aggressive therapy, coming back again to simple methotrexate like that. Similarly, Dr. Sharat was asking about the pregnancy. I think pregnancy is itself a boon when a patient of a rheumatoid lady who's going to go for a pregnancy, we're going to stop them up. As soon as the conceive has been there, I think the presentation will also been there because of the anti-inflammatory effect, the disease is going to settle down itself for 9 months. If not, then at least you can have hydroxychloroquine, sulfasalazine. It's not like always you should give a full trial to stop all the DMRDs if the disease is not at aggressive stage, and to give a fair trial to the nature to make it symptom-free. And then gradually, when the duration of the pregnancy is going to finish, before 2 or 3 months, you can start hydroxychloroquine, sulfasalazine altogether.
Dr.
Right.
Manish, Dr. Manish, like in this continuation, what about your idea with regard to the confusion which is there, whether to follow the reverse pyramidal approach, like attacking the disease which I have seen in the literature and with some prescriptions coming to us. Unfortunately, we in this part of the country in Shillong, we have lots of rheumatoid arthritis and gout. This is typically unusual numbers, which we are seeing day in and day out. So is it a reverse pyramidal approach which we should follow, or a escalating approach from 1, 2, and 3 drugs? So this is what
is whether the patient is having poor prognostic features or not. Poor prognostic feature have to be worked up. Anti-CCP is positive or not, ESR level is being, what is the level of the rheumatoid factor. If it is in a poor prognostic feature, it is always better to go for aggressive management with the 3 drugs. And if works very well, then come down.
That's
But
actually
without poor prognostic feature, in that case, you can trial with the 1 or 2 drugs also. Fair trial.
Right,
Dr.
Dr.
Manish, can I add here something? Dr.
Right.
Manish?
Yes, yes.
Dr. Manish? Yeah.
Please, sir.
Yeah. Dr. Manish, that Shart is saying, 2 drug, 3 drug therapy, as we know, these drugs may take 3 to 6 months to act, when we are adding another drug, it may take another 3 months. So if we have to target the disease early, can't we shift from 3 months, we have given the patient 3 months methotrexate, there is a very little or no fat. Can we directly shift to biologics?
Definitely. See,
no. Just a minute. You have to classify your disease.
Actually,
is it an early disease? Is it a moderate activity or a severe activity? Number 1. Number 2, in a active rheumatology clinic, you will keep on getting patients who have become now refractory what to talk of single, but even double or triple therapy of NSAIDs. So it depends what is the kind of presentation. When there is failure of CS DMARDs, you have to switch over to biologicals.
No, sir, no. I'm saying fresh case, freshly treated case.
It's very
3
severe.
months, no effect.
If it is
Another drug or biologics directly.
the most important thing is many times in our climatic variation, chikungunya and blah, blah, all the conditions, there are so many conditions in which we are not sure whether the patient is developing seronegative or positive arthritis, early condition. Dilemmas are there. Hydroxychloroquine is the safe choice which start acting within 1 month of time in those conditions. But otherwise, as Dr. Jha has already mentioned, we have to classify it. And in that case, methotrexate takes 2 to 3 months to act. Sulfasalazine takes 3 months to act. That for part of the judgment we have to give. I always say to the patient, look, we are going to take your pain off by steroid or blah, blah, whatever it may be. But the disease activity will be taken care of after 2 to 3 months of time. If we need an aggressive approach, then we have to go for 3 drugs. If we feel like that the patient can be, depending upon the prognostic features, is going to settle down, then we can go for a 2 drug. If we are in a dilemma, then methotrexate is always a safe choice drug, gold standard in many seronegative, positive, early psoriatic, spondyloarthropathy. In all these conditions, it works very well, truly speaking.
Only one thing, sir. Someone asked some doubts regarding pregnancy. As Manish Khanna sir told, pregnancy is actually a virtue of nature. It is very protective for RA. Because during pregnancy, from that early pregnancy till delivery, there will be anti-inflammatory medias will be more than the pro-inflammatory mediators. That's why during pregnancy, the disease won't flare up unless and until they have some other risk factors to flare up the disease.
So
In that case, we can
tell to the patients that, look, you are going to get a pregnancy done. Go ahead. There will be no problem. If the problem, we'll take care of. So there we don't, in any of the cases, I think I've never seen a patient who was having a rheumatoid arthritis, methotrexate was being stopped, and during the pregnancy, they were suffering. Most of them, they are not.
Right.
So, sir, a question.
Dr. Lakhar, sir,
It is regarding the timing, it is 3 months or 6 months.
3 months for methotrexate, 3 months, 2 to 3 months for methotrexate to act, 3 months for sulfasalazine minimum to act, and hydroxychloroquine 1 month to act. So
No, sir, no. Before pregnancy, it is 3 months or 6 months.
3 months.
3 months.
3 months. 3 months.
3 months, sir.
And for leflunomide.
What, sir?
Leflunomide is definitely 6 months.
Leflunomide minimum 2 years, sir.
2 years.
So as per the, so we are talking about pregnancy.
Its half-life is very long.
Right.
Clarification with regard to pregnancy.
Friends, I'm very happy that so much of heat has been generated and interest has been created. This will take us further. Now, Dr. Dilip Majumdar is saying,
Professor Lakhar is saying something.
So, Dr. Dilip, will you sum up in 2-3 lines, and then Dr. Sarat Agarwal will propose a vote of
Sir, I have 1 or 2 key questions. Sorry, sir. Important to be discussed.
Right.
Before we close down,
okay, permit Sarat.
Sir, 1 or 2 key questions as orthopedic surgeon, sir.
Okay, please.
Sir, from my side also.
Right.
Okay, sir. Dr. Ranjit has presented very well the perioperative use of the DMARDS. But very important question is that we are managing these patients of arthritis and they eventually will end up there. If I have not mistaken, I have just seen arthroscopy. I'm not concerned with other surgeries because I'll not be touching and nobody will be asking the advice of other surgeries. But about the joint replacement, I'm asking. So those patients who want to undergo joint replacement and are on conventional DMARDS or biologics or whatever. So what should be the duration before the such elective surgeries that these medications should? Can somebody mute?
Okay, Dr. Sarat.
So what should be the ideal duration for these medications to be stopped to avoid such complications during surgery? And for after post-op, when we should restart them? Because this is different guidelines I have gone through and there is no clear-cut idea. So if as Indian orthopedic surgeons, if we can, as IORA can enlighten us on this. I have asked this question in many fora and nobody has been clear about this. They give their own experiences or whatever. So I want to ask the august panel.
Sound is coming from some place. Kindly mute. Kindly mute from wherever the sound is coming.
Dr.
Madan,
Sharath, I think
please.
it has been touched many times during this session also. For conventional synthetic DMRDs, no need to stop practically, unless until going for a biological in a one line.
And
Dr.
what about
And Dr. Ranjit has very clearly said that 5 half-life, earlier the drug should be stopped, and I have said that it can be averaged to even 4 half-life.
But that is for biological.
Sir, may I?
Biology. Yes, yes.
Unless and until the patient is very much.
Ranjit wants to reply.
Okay, it's a general recommendation is 3 to 5 half-lives should be elapsed to relapse before you plan your surgery, elective surgery. There is nothing like anything stopping or not doing surgery in emergency cases. But if surgery like joint replacement, it's a major surgery. You can 5 times the half-life. And
Right.
then plan your surgery. Stop the biologic. Conventional DMRs don't have to stop.
And
I want to add one thing more. It is not a total thumb rule. If you are operating a patient with for a knee replacement who is already a diabetic, there are some conditions are there, debilitated, age is there, some other conditions are there, then of course, if the disease is in the remission stage, settling down state, to be on safer side, if you want, you can discontinue the methotrexate. But still, the documentation is it is safe, it should be given, but not for the biological.
Professor Rajesh.
Sir, regarding methotrexate and NSAIDs, we start with NSAIDs for few weeks or so till this methotrexate X. Then it is increasing the toxicity of the methotrexate. So what should we do?
In fact, as far as NSAID is concerned, their role is established in spondyloarthropathy, not so much in cases of rheumatoid arthritis. There you have to go into rescue of under the shadow of additional use of rather steroids. So NSAID for 4 weeks is the recommendation, that also not 1 but 2 NSAIDs in spondyloarthropathy, and no such recommendation exists for rheumatoid arthritis.
That is why it is always better to go for a pulse therapy.
All right.
Steroid and come
Sir,
back.
one thing, Rajesh sir, you asked now when to restart methotrexate in case of lactation. The minimum duration we should stop methotrexate is till 6th month of breastfeeding. Exclusive breastfeeding period should be free of methotrexate. After 6th month, we can start if the patient requires methotrexate in case.
Right. So now it is the turn of.
Sir has a question, sir. I think
who?
Professor Lakhar.
Lakhar? He is the president. Where are you, Lakhar?
Sir, are you here?
There is a hand raised, sir, from his side.
Okay. Professor Lakhar.
Sir, can you hear me? Yes, can you
Yes,
hear me,
sir.
sir?
Please.
So, sir, before we have Ms. Dr. A.P. Joshua in our meeting, so we can analyze when this can be organized.
Your voice is not
voice
clear.
cracking.
Okay.
Lakar, your
So, when this meeting can be organized,
Okay, so you are talking about IORACON. So let us first close this and then we discuss it. So now, Sarath, this is your turn for vote of thanks.
Okay, sir. Thank you, sir.
Right.
It has been a wonderful experience so far in this new journey on rheumatology initiated by IOA, which is helping us to delve into this very important area and learn to solve problems of our patient as orthopods in our day-to-day practice. I begin by thanking Dr. Ram Chadha, President-elect IOA, for his motivational words and support and encouragement as always. I thank Dr. Naveen Thakkar, Secretary IOA, who has always been an encouragement for all of us. I thank especially while he was busy in OT and he could ensure his presence in spite of his busy schedule. I thank Dr. Shantanu Lahakar, President IORA, for helping us to establish this field of rheumatology under aegis of IOA. My sincere thanks goes to Dr. S.S. Jha sir, whose enthusiasm is infectious and wide experience in this field is helping to take this shape in a most desired way. I thank the faculty for today's webinar on DMARDS for their hard work and preparations, which includes Dr. Rameshwar Gupta from Gwalior, Dr. Ranjit Kumar Singh from Patna, Dr. Madan Jayaraman from Chennai, Dr. Chinmoy Das from Tejpur, Dr. Arul Kumar from Bhubaneswar, Dr. Partha Pratim Das from Tejpur, Dr. V. Senthil from Chennai, Dr. Manish Khanna from Lucknow, Dr. Rajeshwar Gupta from Jammu, Dr. Dilip Mazumdar from Calcutta, and Dr. Sanjay Keshkar, Calcutta, in his absentia. My thanks goes to delegates who have attended this webinar, and without their participation, we could not succeed in fulfilling our aim of transfer of this information to our patients in society. Of course, not forgetting my sincere thanks to the team of IOA OrthoTV, which includes Dr. Ashok Shyam, Dr. Shamshul Huda, and Dr. Neeraj Bislani, who is constantly arranging us and helping us in this webinar platform. Once again, thank you all.
Thank you very much. But before we close, we have Professor Dilip Mazumdar. He always has the last word. So last word from Professor Dilip. Are you awake, sir?
Yeah. I'm. Thank you, Professor Jha. This is a new addition with the new blood that has come to our this association, and I believe that the new generation that we are hunting for several years, that how to imbibe the new generation to continue for the propagation of the science and the arts of treating patients. So thank you, Professor Jha and others, Manish and all, that you have actually contributed to this focus, that so that in the magnet, these people are coming, more people will be coming in the new time next year, or even with the 2 to 3 months time. Even you can find in the Varanasi conference also new generation will be imbibed there. So I am very happy to see that, because this was my aim and ambition and my dream, that how the new generation will be imbibed here. All are doing surgery, all are doing TKR, THR, everything doing, all rheumatoid cases. But the new generation awakening, that is actually you are responsible as a father figure. You are responsible for the imbibation of the new generation, which is very much thrilling. And I enjoyed this evening and the discussion today only because of you and Manish. Thank you very much. Thank you.
Yes, it has been a long desire.
In the end, I would like to invite everybody to come to Shillong, the Scotland of East. Probably you will enjoy, and we'll have the experience and learning from all of you, the senior
I thought
stalwarts of rheumatology.
Thank you.
I thought there is a dinner to which he is inviting. Okay.
So, sir.
Okay, so now this meeting is closed, and
listen to Lahakar.
Before final closure, we have our distinguished Dr. Jaiswal. Are you here from Varanasi? Yes. So, Professor Lahakar.
Yes, I am very much.
You start the discussion. The topic is IORA conference at Varanasi. Is that right?
Yes, sir.
Okay. Somehow your voice is resonating, Professor Lahakar.
Yes, sir.
number one. Number two, I think we are going to discuss about the date.
Yes.
Dr. Chinmay is here? No, perhaps he has left. Chinmay?
Sir has left. Sir
Okay,
has left,
okay.
sir.
So, your statement, Professor Jaiswal, Dr. Jaiswal.
Jaiswal sir is mute.
Dr. Jaiswal.
Jaiswal is here or not?
Yes, sir. Yes,
He-
sir. I'm here.
Yes, please.
I'm planning my IRACON in September 1st.
Right.
Sir, tell us the dates, sir. Dates. Please finalize the dates.
September 1st week, Saturday, Sunday.
First week, let the first week be over. So end of the first week.
Yes, sir. End of first week.
Sir, first week, Saturday, Sunday is on 2nd and 3rd of September. If the end of first week, it is 9 and 10.
8 or 8, then 9.
Keep it 8, 9, or 10, whatever it is.
Sir, 8 is Friday, 9 is Saturday, 10 is
Right.
Sunday.
Right. So 8, 9, 10, it will be 2 days, or you wanted only
2
2
days,
days?
9 and 10, sir. 9, 10.
9,
Sunday will
10,
be
10.
fine.
Right. Fine.
No,
Right.
hey,
Manish?
Lakar, 1 point, Lakar.
Manish?
Dr.
Yes,
Lakar,
sir.
1
I think
point, because
we
the
should
pending
now-
hand surgery.
Now,
hand
Manish is
workup
saying
is there.
something.
So Manish, would you
Oh.
allow would it be possible that the half day hand will be there in the?
No, that detail we will come to later.
So
First,
it is
Okay.
better we should now close the meeting and then we can
Right.
have a closed discussion.
So
officially-
dates are fixed, right?
So
What is the date?
and we'll request the IOA house to now close the recording. So that we
Right.
can discuss. Thank you.
Thank you.
Right?
Okay, thank you.
Bye.
Thank you,
Good night.
Lakar
Thank
Saab.
you, everybody.
Thank you,
Thank you,
everybody.
sir. Thank you, Jas sir. Thank you, everyone. Bye,
Okay,
sir.
Thank you. It was very nice meeting.
Thank you, sir. Thank you, sir.
Chalo.
Thank you, sir.
Rajesh, we'll see again. Rajesh, yeah.
Good night, sir.
Good night,
Yeah,
sir.
Definitely.
yes, see. And
Definitely.
Madan, we'll see
Bye, sir.
again.
Bye, sir.
Yeah, bye,
Bye, bye,
bye.
bye.
Thank you, sir.
Very nice meeting,
Yeah.
very nice.
Good night, everybody.
Good night, sir.
Good
Good
night.
night, everybody.
Shubhratri.
Shubhratri, huh?
Majumdar sir,
Yeah,
Majumdar sir, any
Yeah.
date is fixed in the September?
pardon? Date is not fixed in the past Saturday, Sunday.
So first,
Jaiswal
Saturday.
told past Saturday, Sunday,
Sunday of the September,
September, first week.
first week. Okay. Okay, sir.
Okay, that is decided, but the hand is not decided. And
Yeah, answer.
we will talk with our Das, Chinmay Das.
Okay. Okay, sir. Good night then. Good night.
Good night, good night. Yeah,
Good night, sir. Good night.
yeah. Thank you. Arul, thank you, Arul. Thank you, Jaiswal.
Thank you, sir. Thank you. Good night.
Thank you, good night. Thank you, thank you.
Joshua.
Jaiswal is here.
So I give my personal thanks for joining over here in the meeting.
Yeah, Jaiswal has come and we gave him thanks. Okay, see
Thank
you.
you, sir.
Thank you, thank you.